Welcome to the webcast, Understanding and Protecting the Kidney, Identifying Patients at High Risk for Kidney Failure in the Cath Lab. For your information, this program is provided by North American Center for Continuing Medical Education, and it is supported by an educational grant from Osprey Medical. Hi, I'm Dr. Shweta Bansal. I'm an Associate Professor of Medicine in the Division of Nephrology, Department of Medicine here at UT Health, San Antonio. Thank you so much for having me here today to talk about understanding and protecting the kidneys in Cath Lab. I'll be presenting the first half of this talk, and second talk will be done by Dr. Anand Prasad, who is the cardiologist in my institute. And during the first half of my talk, I will discuss about the deep connections heart has with the kidneys and kidneys has with the heart. And I'll talk about what are the reasons behind these deep connections. And in the second quarter, I will talk about different types of kidney diseases one can have and how does the contrast damage the kidney, taking account that deep connection which we would learn between heart and kidney. And before I move on, I just want to make sure that I declare that I have no conflict of interest in relationship to this talk, and I have no disclosure to make. So let's talk about the deep connections between heart and kidney and why we are here to talk about kidneys in the Cath Lab, okay? So I start with this slide. So basically, this is the data from a DEAR registry. In that registry, patient information was kept who were admitted in the hospital with the acute decompensated heart failure. And these patients had their kidney functions examined. Some of them they had before, but most of them had kidney function assessed in the hospital. And the way kidney function was examined was measuring their estimated glomerular filtration rate in ml per minute. So as you can see in this slide, only 10% patients had normal kidney function as seen by GFR above 90 ml per minute. But rest of the 90% of the patients had reduced kidney function. And you see majority of patients, like about 65% had at least moderate kidney disease because their kidney functions were below 60 ml per minute. Almost half of the patients had their GFR 30 to 60, which is equivalent to stage 3 kidney disease. And about 12% patients had 15 to 29, and almost 7-8% patients had advanced kidney disease, less than 15%. So it suggests that presence of kidney disease is very high in patients with heart failure. So this study does not tell you exactly what was the reason for a drop in the kidney function. It could be directly related to the heart disease, or those renal dysfunction could be present already in those patients. So similarly to what you saw, that kidney disease is so prevalent in heart patients, this slide shows that kidney patients have higher rates of heart disease also. So this is the data from USRDS website, which captured 5% of Medicare population. And they have basically the detailed lab analysis and their medical history. And on the blue bar shows the prevalence of heart disease in patients with kidney disease, and the yellow bar shows the prevalence of heart disease, any heart disease, in patients without CKD. So you can see any type of kidney heart disease, including cardiovascular disease or acute AMI, or congestive heart failure, or valvular heart disease, or cerebrovascular disease, they are significantly higher in patients with kidney disease than without the kidney disease. And you will say that, yeah, the risk factors which cause CKD also are responsible for heart disease, like patients who have diabetes, heart disease, the most common cause, diabetes or hypertension, the most common cause of kidney disease, they're going to cause the heart disease also. So it's not that patients who have kidney disease are more prone for heart disease, it's the risk factor. But in these analyses, when the prevalence of heart disease was accounted and adjusted for the risk factor in patients with CKD independently associated with higher risk of heart disease. So that tells you that kidney disease itself makes one prone to have heart disease. So what is the reason for this deep connections between heart and kidneys? Why patients with heart disease have more kidney disease, and why patients with kidney disease have more heart disease? So let's talk about normal first. And I'm a nephrologist, so I'm going to talk about the kidneys first. So everybody knows we have two kidneys, and here is the cross-section of a kidney. And so kidneys are supplied by renal artery, which divides into the segmental artery, then the interlobular artery, and then small arcuate arteries, and eventually branches out. These arteries branches out in capillaries, and which serves the individual unit of kidney, which we call nephrons. And this is the basically efferent arteriole, and it branches out, loops on itself, make the glomerulus, which cause the blood to filter to form the ultrafiltrate, which goes into the tubules, and the rest of the blood goes back. And this is a basically nephron, which is the individual function unit of kidney. Each kidney have 1 million nephrons. So every healthy person have about 2 million nephrons. And just for your knowledge, kidneys get 1/5 of cardiac output. So usually cardiac output is 5 liters per minute. So kidney gets 1 liter per minute. So very vascular, very active organ. And then here you filter out every minute. Normal healthy kidneys filter out 125 ml per minute. Each nephron is doing that. And each nephron, basically collectively, you are filtering out 125 ml per minute. So total in a day, when we have 1440 minutes, you filter out 180 liters per day here at the level of the glomerulus into the proximal tubule of the nephron. But you must be thinking that average urine output when it comes out here is only 1.5 liters per day when it comes out as urine. So why we filter 180 liters here at the glomerulus level and when only we make 1.5 liters of urine every day? So the reason behind that is that rest of the 178.5 liters of filtrate get processed in this nephron over time to reabsorb all the good stuff back and leave the toxins into the urine, and any extra electrolytes, sodium, water, potassium, acid we consume in that day will go out in that 1.5 liters as the impurities, and here you have clean blood. So that tells what are the jobs of the kidney. So job of the kidney is removal of the waste and toxins, which we generate when we eat and metabolize the food. The next job of the kidney is to keep the blood pressure in under normal range. And how it does it? By getting rid of the extra salt your body, your kidneys do not need. So by maintenance of the salt homeostasis, kidneys maintain the normal blood pressure. Then kidney takes care of your acid-base balance by getting rid of all the extra acid you make when you metabolize the food. And by keeping your potassium, phosphorus, magnesium, calcium in balance, by either reabsorbing it or by excreting it depending on your intake. And lastly, kidneys also make hormones like erythropoietin, which maintains your hemoglobin, renin, which maintains your vascular integrity, and then hormones like 1,25-dihydroxyvitamin D to maintain your bone mineral status. So kidneys do a lot of jobs for you. Most important is the removal of waste. So that brings us to the question that what happens to the kidney when there is heart disease, or in another words, when there is a decrease in the cardiac output, how it's impacting the kidney function. So let's go over that. So when you have heart disease for whatever reason and you're having decrease in the cardiac output, that decrease in the cardiac output leads to the activation of your arterial baroreceptors. So you know that you have baroreceptors in your carotid artery, in your aortic arch, which senses your volume status all the time, and their job is to maintain the perfusion to your vital organs. So if there is a decrease in the cardiac output, the baroreceptors do not get perfused very well, they get stimulated, and they bring on the compensatory mechanism to bring on enough volume in the baroreceptors area that you have perfusion to the vital organs. So what are those compensatory mechanisms? So stimulation of baroreceptor leads to stimulation of the sympathetic nervous system, activation of the renin-angiotensin-aldosterone system, and activation of the vasopressin. And what these different neurohormones do for you. So all these three things, the vasopressin, the sympathetic nervous system, the renin-angiotensin-aldosterone system, they cause vasoconstriction of the systemic vascular system and especially the renal arteries. And by causing the increase in the systemic vascular resistance, they try to bring the blood pressure or the area where the baroreceptors are towards normal and maintains the circulatory integrity. The other things these neurohormones do, they cause retention of sodium in the kidney and retention of water in the kidney. So the decrease in the cardiac output, which is impairing the integrity of the circulation, now is trying to be maintained by the increase in the systemic vascular resistance, by increase in the retention of sodium and water. So these are the compensatory mechanisms. So these are good. They try to bring the maintenance of the arterial circulatory integrity. But what's happening during this process, there is increase in the renal artery vascular resistance causing decrease in the renal blood flow. So you're good. You're trying to maintain the perfusion to the vital organs like brain and heart, but at the expense of the compromise of the renal blood flow. So in the beginning, when you have decrease in the renal blood flow, you still maintain the GFR, the glomerular filtration rate, by the autoregulation mechanism you have in the kidney. However, if the cardiac output is really bad and you keep on having these compensatory mechanisms stimulated, renal blood flow keeps on going down, and then there is an exhaustion of that autoregulatory capacity, and that leads to decrease in your kidney function, means decrease in the glomerular filtration rate. So in addition to this, if you have any other superimposed insult like infection, sepsis, which cause further decrease in the renal blood flow, or you have NSAIDs like Aleve, Advil, Motrin, ibuprofen, they will cause further decrease in the renal blood flow because they inhibit the prostaglandins, which are the vasodilators, or like Contrast, which is another vasoconstrictor. So you will impair the renal blood flow more, which is already compromised from a decreased cardiac output, and you bring on decrease in the kidney function. So after that, we discuss what happens to the kidneys in decrease in cardiac output. So similar, the question is what happens to the heart when there is decrease in the renal function. So renal functions are basically acute kidney injury or chronic kidney injury. So acute kidney injury, and I'll talk more later on, like you having sudden decrease in the kidney function for whatever insult. So you have decrease in the GFR, and now you're not filtering out enough fluid. So you're having sodium and water retention, causing volume expansion, which leads to increase in the preload and putting stress on the heart. Sodium and water retention causing hypertension also, putting stress on the heart. And we have learned over the last few decades that the injured kidneys, they release more sympathetic activity into the system, more increase in the renin-angiotensin-aldosterone activation, and all these things put stress on the heart. And then acute kidney injury still produces a lot of inflammation, giving monocyte activation, endothelial activation, and putting stress on the heart. So that's how in the acute kidney injury, the heart gets affected. On the other hand, in chronic kidney disease, in the beginning, when the damage is slowly happening over time, the reason which cause kidney disease, like smoking, hypertension, obesity, dyslipidemia, are also affecting kidneys. But as one keep on getting more and more damage, more nephrons going dysfunctional, and there's decrease in the GFR, then you're gonna start have problems for which kidneys take care of you. We just heard collection of toxins. So these uremic toxins put stress on the heart. Then you're going to have problem with your bone and mineral metabolism because you do not have enough vitamin D, you have excess of phosphorus, you have excess PTH, parathyroid hormone, and all those things put stress on the heart. Your sodium and water retention keeps on happening from the beginning of the chronic kidney disease, and you're collecting the salt and causing hypertension, and that's putting stress on the heart, causing left ventricular hypertrophy and medial vascular calcification. And as you keep on having advanced kidney disease, these things keep on going into circles and causing more damage to the heart. And once you start the dialysis itself is a big stress because you're getting exposure to the foreign body in terms of filters, cause more inflammation and more damage to the heart. So these are the mechanisms by which you are getting one organ affected when the other organ goes down. So now I want to tell you a patient story, like why we are here, why we are talking about these deep connections. So let's listen to this patient story. So here I have a 65-year-old female who has hypertension, diabetes affecting her eyes, her nerves, and she had coronary artery disease also, underwent a percutaneous coronary intervention in 2015, and now she ended up having a grade 2 diastolic dysfunction. She comes to the ER with complaint of chest pain, going on for 2 weeks, intermittent, comes on with activity, and she came to ER finally as she was not getting any relief with sublingual nitro. So in the ER on examination, she was hemodynamically stable, no fever. Her JVP was 7 centimeter. She had no RAS on the lungs. Her heart was regular, normal sounds, and she had trace bilateral peripheral edema. On EKG, there were ST segment depression in lateral leads, which were new, and troponin was checked, and at the time of presentation, it was 0.06, but it went up to 1.2 nanogram per ml at hour 3. So here we are dealing with a non-ST segment elevated MI or unstable angina. So the next step is basically doing cardiac cath. Like you don't want to mess up with stress tests, or you just go for cardiac cath. So the first thing which comes to your mind as a cardiologist or interventional cardiologist or as a hospitalist and the team is like, oh, we want to make sure that kidneys are fine because we have to give the contrast to this patient. So her creatinine was 1.3. And normal lab value is 0.8 to 1.5 for the local lab. And on urine analysis, she has 1+ protein. Her protein creatinine ratio in the urine is 1.2 grams per gram, hemoglobin 13. So like, oh, creatinine is good. And she's looking okay, let's take her for Cath. So she goes for Cath, and she found to have significant disease in LAD, and she had another stent placed there. And then she's kept in the hospital. And what's her follow-up? So at 24 hours, her blood pressure is 150/80. She has jugular venous distension now, 10 centimeters, and she has 1+ edema bilaterally in her ankle area. And her serum creatinine today is, after 24 hours of Cath, 1.8 milligrams, which has gone up. And urine output, she's maintaining 50 ml per hour. Then you're like, oh, creatinine went up, so she did not get discharged. She's in the hospital, and over 48 hours, its creatinine is 2.4, but then over the next few days, it stays there, 2.4, and after 5 days of Cath, it starts coming down slowly. So now you have question in your mind, did she have kidney injury? Like her creatinine went up, and if yes, what kind of kidney injury she had? So I'm going to talk about different types of kidney disease. The next question is like, why she had kidney injury? Like she was looking okay. Her creatinine was only 1.3 begin with. So to understand that, we'll talk about the risk factors. And then the last question is like, okay, her creatinine went up, but it came down already. So do I need to worry about that? It's like transient process. It happened, and I'm glad I did that Cath, and we gave her contrast, but eventually the final answer was good because her creatinine came down. So do I still worry? So to answer that question, you'd go over short-term and long-term prognosis in patients who have this kind of kidney damage. Okay? So here is kidney diseases. We have 2 types of kidney disease, acute and chronic, and that depends on the duration of your abnormality, either in the kidney function or even having presence of blood in the urine or protein in the urine is considered kidney disease. So if the duration is of those abnormalities is less than 3 months, you call it acute. But if those abnormality remains present and does not get better after the insult for more than 3 months, so it means there's some scarring now in the kidneys and you are left with kidney damage. So then you call it chronic kidney damage. Then we divide acute kidney injury like different causes. So it's an approach basically based on the causes if they were present before the kidney, or they were directly related to the kidney itself, or they were related to process of the urine after it left the kidney, so post-renal. So among the pre-renal causes are hypovolemia, which makes sense. You do not have enough volume because you lost either as a blood or in the diarrhea or vomiting, and now your baroreceptors are not happy, blood pressure is low, and you're having sympathetic nervous system and renin, angiotensin, and aldosterone all up, so your renal blood flow to the kidney is low. The next common cause is decreased effective volume because of heart or liver disease. So in these patients, your total volume is fine, but the problem is the volume is not in the right place. In heart failure patient, the volume is more on the venous side and in the interstitium rather than on the arterial side. So again, your baroreceptors are not happy, and you're having increased renin, angiotensin, and sympathetic nervous system, causing renal vasoconstriction and decreased renal blood flow and kidney injury. And in liver disease, again, total volume is fine, but it's in the arterial system, which is very dilated. So the baroreceptor feels there is not enough volume. So there is not enough effective volume, which is making baroreceptors happy, and you end up having high renin, angiotensin, sympathetic nervous system, which cause renal vasoconstriction. Or you can have problem directly into the kidney vessels itself. So like contrast, it directly stimulates and I'll go over later on, cause stimulation of the neurotransmitters, which cause renal vasoconstriction. Or you have some anatomical problem in the renal artery or the vein, like you have a clot or thrombus or just atherosclerotic lesion in the renal artery, that kidneys are not getting enough flow and having damage to the kidney function. Among the renal causes, then we divide them into based on if they're damaged to the glomerulus or to the tubules or to the blood vessels in the kidney. And there are all these different regions, but I want you to pay attention to the contrast in the tubular interstitial section, because contrast not only causes decrease in the renal blood flow, but can cause direct injury to the tubules and cause decrease in the kidney function and renal failure. Among the post-renal, like you can have obstruction to the urine flow, either because of the stones in the tract or extrinsic mechanism like benign prostate hyperplasia, or there's a tumor or stricture compressing the urethra or your ureter and causing kidney damage. The next question is, how do you define acute kidney injury? When you call it acute kidney injury, is like whenever creatinine is up, and how much up, and how do I know if this is up for a long time or it's just now? So before 2000, really we did not have good definitions of what you call acute kidney injury. But in kind of mid-2000 or like 2002 came the RIFLE criteria, RIFLE by ADOKI consensus meeting. And they define acute kidney injury as increase in serum creatinine more than 1.5 times above the baseline within 7 days. And they divided the acute kidney injury into staging of by RIFLE. R is risk, if the increase in serum creatinine is 1.5 to 2 times. I, injury, if the rise in serum creatinine was 2 to 3 times. S, if it was more than 3 times. And they call it loss if it was persistent acute renal failure for more than 4 weeks. And E, ESRD, if patient is needing dialysis for more than 3 months. And another criteria was the urine output criteria, based on how much urine output you're producing in ml per kilo per hour for 6 hours or 12 hours, and you can look at these criteria. That kind of helped a lot, started defining acute kidney injury for the research purposes, for epidemiological purposes, and planning purposes, because before that there was no consensus in the definition. But over time, people realized that this definition was very good sensitive, but no specificity, a lot of false positive cases. So then came the AKIN, Acute Kidney Injury Network criteria, which kind of tell that increase in serum creatinine by 0.3 or more than 1.5 times baseline within 48 hours instead of saying 7 days. And then they divided into 3 stages, taking away the loss and ESRD part with the almost same criteria, and urine output criteria were still same. So this definition was definitely more specific, but then there were issues with false negative cases. So finally, in 2012, KDIGO, the Kidney Disease Improving Global Outcomes, they came with this criteria, which they mixed the Reifel and Aiken criteria, and they called the definition of AKI as increase in serum creatinine of more than 0.3 milligrams per deciliter above baseline over 48 hours, or more than 50% over 7 days. So this definition was sensitive as well as specific, decreasing the false negative as well as false positive cases. So now we have at least definition what is acute kidney injury. So that brings us to the question why we are so getting finicky about recognizing AKI. Why is it important to recognize AKI? These kind of questions started to get answered in late 2000. And Steve Coca is a guy, like we are almost same time, and during his fellowship, he did this meta-analysis of studies with patients who had acute kidney injury and who had follow-up of at least 6 months after they sustained acute kidney injury. And those injuries could be sustained in variety of clinical settings. Like they were critically ill patients, liver transplant patients, had the PCI or cardiac surgery or lung transplant, aortic surgery. So all sorts of variety of clinical settings where they sustained AKI. And then they looked at the death rate in patients who had AKI versus who did not have AKI. And as you can see clearly on the rightmost side of this figure, which shows the relative risk ratio of death for patients who had AKI versus non-AKI. So patients who had AKI, they were 2 to 9 times at higher risk of death than patients who did not have AKI. And this risk ratio was after adjustments for the underlying risk factors. So it was showing that AKI itself make you prone for increased mortality at 6 months. And not only that, it's making you only death, and they also showed that the relative risk of having MI over next 6 months was 200% or 2 times higher than patients who did not have AKI. And they did not have exact data to compare the occurrence of chronic kidney disease in future, but definitely patients who had AKI episode, they had higher incidence rate of developing chronic kidney disease or ESRD in future. So these were the first studies started showing us that it's important to recognize AKI because that makes you prone for having cardiovascular as well as all-cause mortality in future. And similar kind of results were seen in patients who underwent PCI if they had AKI. So this study from 2014 as the NCRDI data, where they looked at like 30,000 patients who underwent PCI and then compared their in-hospital death, bleeding, and risk of bleeding and MI, in-hospital MI, in patients who had AKI versus who did not and versus who had dialysis. So you can see the patient who needed dialysis, they had significantly higher in-hospital death, in-hospital bleeding, in-hospital MI rate compared to patients who had AKI but did not need dialysis. And the patients who had AKI had definitely higher rate of death, bleeding, and MI compared to patients who did not have any AKI. So AKI was clearly giving you higher risk of cardiovascular disease and death once you sustain it. And it's been also shown that worse the stage of the AKI, the worse the outcome of mortality. Okay, so last part about contrast-induced nephropathy. What is contrast-induced nephropathy? Contrast-induced nephropathy is the rise in creatinine of more than 0.3 milligram per deciliter or more than 50% from baseline within 3 days of contrast administration. So pretty similar to the KDIGO definition, but you have to have a contrast administered before that, and you do not have any other explainable cause. Like patient cannot have complete obstruction in urine and you're having increase in creatinine and you call it contrast-induced. No, without any other explainable cause, if you have rise in creatinine after contrast, it's contrast-induced nephropathy. So let's look at our patient. She had creatinine of 1.3, and she had, this is a good protein creatinine ratio of 1.2 gram per gram. It's pretty high protein in the urine. Normally you would be having less than 0.2. a 70-kilo person. And then this lady, after having Cath and contrast administration, her creatinine went up to 1.8. So yes, and on basically next day. So she had rise in creatinine by 0.5 and almost 40% from her baseline. And then she had it up for next 2-3 days. So yes, she definitely had the contrast-induced nephropathy because there was no other explainable cause. She did not have any infection. She did not have any obstruction. She did not get any other nephrotoxic agent like NSAIDs or gentamicin, and there was no skin rash that suddenly she was developing glomerulonephritis. So no, none of those were there. She had contrast-induced nephropathy. So that asks us, like, what's this about contrast? Why contrast gives you nephropathy or nephrotoxicity? So let's go over the mechanism of contrast-induced nephropathy. So when you inject contrast into blood vessels, it goes in next few minutes to the renal vasculature because kidneys get 1 liter per minute of blood flow every minute. And initially, the contrast administration causes endothelium-independent transient vasodilatation, and that vasodilatation basically increases your GFR in the beginning, and you filter more fluid in the proximal tubule. And when that more fluid goes to the macula densa, it says like, oh wow, why I'm getting so much of fluid, and it causes the tubuloglomerular feedback by releasing adenosine, and adenosis causes renal vasoconstriction. Okay, so after initial transient vasodilatation, then there is adenosine-mediated intrarenal vasoconstriction, and after a few minutes, contrast administration caused release of the endothelin, and endothelin is a pretty potent vasoconstrictor. So now you're having another stimulus for the renal vasoconstriction in addition to adenosine. And in the animal model, it's been shown that contrast administration causes prostaglandin dysregulation, so that you have less of the prostacyclin, which is the vasodilator, and more of the prostaglandins, which are vasoconstrictor. So all these three things, the dysregulated prostaglandin, endothelin, adenosine, cause sustained intrarenal vasoconstriction, which lasts for hours. So what are the consequences of this vasoconstriction? Vasoconstriction slows down the blood flow in the kidney and cause increased exposure of the contrast in the kidney because there is increased transit time, and the tubules get exposed to contrast for a long time. And all these things cause, and contrast prolonged exposure cause direct cellular injury and cellular death, and which stimulates the production of oxidative stress and inflammation. And another thing which happens with intense intrarenal vasoconstriction, medullary hypoxia. So medulla is the region of the kidney which is already relatively hypoxic. There is not enough good blood flow. And now on top of that, you're having contrast with the slow transit time, which is increasing the viscosity of the bloodstream, increasing the osmolarity. So you have further medullary hypoxia, giving the ischemic injury and death, stimulating oxidative stress, and eventually leading to acute kidney injury. This is the pathology of contrast-induced AKI. So on this first panel on A, you see the normal glomerulus and normal tubules lined by beautiful tubular epithelial cells and dense nuclei. But if you see on panel B in the low power and panel D in the high power, so now you see that tubules are having loss of cellular details. The cells are not as beautifully formed, and the nuclei is getting condensed and pycnotic, and there is a release of cellular debris in the tubules, causing obstruction completely. On the left side, on the bottom, you see the vacuolization of the proximal tubule because of contrast is an osmolar load, giving you the vacuolization of the proximal tubule. And then in the bottom, the panel A and B are showing the normal medulla, where you do not see glomerulus, just the loop of Henle, like thin tubules, very beautiful on the panel A. But on the panel B, you see there is a cellular swelling and eosinophilic debris in the tubules from cell damage causing obstruction. So this is that's what happened when somebody gets contrast. This is not the human pathology. This is more from the, this is all from the rat studies. So to summarize the pathogenesis of contrast-induced nephropathy, there's a reduced renal blood flow, direct cell injury because of the imbalance of vasoconstrictors and dilators, increase in endothelin, causing direct smooth muscle contraction, and then endothelin stimulates NF-kappa B and COX-2, causing more inflammation. And in diabetic patients, they already have high endothelin, and now on top of that, you give contrast, there is a further stimulation of endothelin. Increase in the adenosine detox, there's a failure to increase in the nitric oxide and prostacyclins. And diabetic patients, they already have impaired renal nitric oxide generation, and with contrast, it gets further compromised. And that's why patients with diabetes are more prone for contrast injury. And there is increased medullary ischemia and direct cell injury. How do you diagnose contrast-induced nephropathy? So this is a pretty good cartoon to explain that. So when you give contrast, the decrease in the kidney functions happens right away. This dark blue line showing that your real GFR goes down right away and comes back slowly over the next few days. However, the way creatinine measures the kidney function, creatinine takes time to go up after the injury. So you do not know till next 24 to 48 hours that you had the contrast damage, which contrast-induced damage, which has already happened, because creatinine is not very sensitive to tell you at time 0 or hour 6. And to overcome these deficiencies of creatinine, investigators are working on different biomarkers which go up within few hours. So few of those biomarkers are NGAL or kidney injury molecule or cystatin C. And as you see, these things go up within 4 to 6 hours of contrast-induced damage, and they can tell you sooner than later that patient had the contrast-induced damage. But they are definitely attractive, but we do not know still how to use them in clinical practice. So the last point about contrast-induced nephropathy, that you must be thinking we give contrast to so many patients, but we don't see contrast-induced nephropathy all the time. So why some patients get it and why some patients not? So the chances of development of contrast-induced nephropathy depends on the presence of number of risk factors. A patient who is otherwise totally healthy, they're not going to get contrast-induced nephropathy. On the other hand, if you have 9 risk factors, your chances of developing nephropathy is 45% compared to 0% if you do not have nephropathy, and being shown in different types of cohorts. So what are those risk factors? As stated, it's no risk factor, incidence of contrast-induced nephropathy is less than 1%, but if you have risk factor, then incidence can be up to 20%. And the risk factors are these following, and I'll go over them, but I want you to pay attention, like what we just learned, how the contrast-induced nephropathy happen and the connections between heart and kidney, why people are prone. So if you have chronic kidney disease, especially diabetes and low GFR, you are prone for contrast-induced nephropathy. We saw that because diabetes and CKD already compromising your nitric oxide level. You already have high endothelin level. And on top of that, you give contrast, they're going to get worse. So you're going to have damage for sure. Congestive heart failure, cirrhosis, what's wrong with them? We just learned. When you have heart failure, you have cirrhosis, your underlying renal blood flow is already compromised because of high neurohormones. And now on top of that, you're giving contrast, you're compromising the renal blood flow further. You're going to have decrease in the GFR. Aging, female gender, because with age, your kidney functions go down. You're not prone for taking other insults as well. Hypovolemia, again, you're dry, your volume is low, your blood flow to the kidney is already bad because of the neurohormones. So contrast on top of that, yes, you're going to have contrast-induced nephropathy. Other nephrotoxins, again, you're compromised already, and top of that, you're having another nephrotoxin. And Dr. Prasad will go more in details these other risk factors, how the increased risk factors gives you higher incidence of contrast-induced nephropathy. But all these support the concept of multiple hits in the pathogenesis. Only one disease is not enough. So I'm telling you that identifying chronic kidney disease is very important to define anybody's prognosis or like their chances of developing CIN. So how do you know if the patient has chronic kidney disease? We talked about the acute kidney injury, but how do you know if your patient has chronic kidney disease? Because creatinine is really not the best marker or value which tells you that what are the kidney functions. KDIGO in 2013 put out this classification for chronic kidney disease, dividing them into 5 stages. If your kidney functions are above 90, it's normal or high. 60 to 90 is mildly decreased, G2. G3 is when you have 30 to 60 ml per minute of GFR, and G4 is 15 to 30, and G5 is less than 15. So patients who have GFR below 60, they are definitely more prone for having kidney disease. And not only decrease in the GFR, but presence of albuminuria is also tells you that you have chronic kidney disease and you are prone for kidney damage, which we do not, the other non-nephrologists do not pay that much of attention. Albuminuria, you check basically by checking the albumin and creatinine ratio in the urine, in the spot urine, or you can just do the dipstick. And if it is coming positive, it's basically you have albuminuria and you're at high risk. If it is more than 300, that's severely increased. So I just give you a few examples. How do you define, look for CKD? So MDRD.com is a good resource. You can easily have on there are basically apps to calculate the GFR. And MDRD.com, they give you GFR by different definitions, by CKD epicreatinine, CKD epicystatin, and MDRD. And the latest is the CKD epi, which came in 2009, and it's pretty good. You can use in most of the patients. So if you have a 25-year-old male with creatinine of 1, it gives you the GFR of 119 or 104, which is pretty good. This patient is safe. You can give contrast. On the other hand, our patient who had creatinine of 1.3, 1.2, it looks pretty good. 1.2 is not high. But you look at her age. She's female, and she has a history of hypertension. And when you put this 1.2 to calculate her GFR, it comes 46, which tells you that she has a stage 3 CKD. And if she has proteinuria also, she is definitely high risk for developing contrast-induced nephropathy. And that's what happened with our patient. She already had underlying kidney disease with high degree of proteinuria, and she ended up having CIN. Okay, so I think that summarizes my part of the talk. And I would just want to repeat that contrast-induced nephropathy is defined as rise in creatinine within 3 days of exposure. It's very common, more in patients with more risk factors, and it's not something which we can ignore easily because it gives you worse short and long-term prognosis. And prevention is definitely the key. I would say, being a nephrologist, recognition of CKD is very important. And I let Dr. Prasad take over from here to go over the more about the risk factors and more what can be done to prevent the contrast-induced nephropathy. Thank you so much for your time. I really appreciate this opportunity given to me. Thank you.
Hi, my name is Anand Prasad. I'm an associate professor of medicine at UT Health San Antonio, and I'm the director of the Cardiac Catheterization Laboratory at University Health Systems. I'm here today to talk to you about understanding and protecting the kidneys and how we can identify patients at high risk for kidney failure in the cath lab. These are my disclosures. So my focus area will be first understanding the influence of comorbidities for patients in the cath lab. And it doesn't matter whether you're involved with coronary procedures, peripheral arterial procedures, or structural heart, including TAVR, you're going to face acute kidney injury. And there's going to be a common theme here where you're going to deal with shared patient comorbidities. Our population is getting older, so age, diabetes, underlying chronic kidney disease, heart failure, and hypertension. On top of that, you're going to have specific procedural factors, and those may vary by the type of procedure we're talking about. So volume of contrast dye, volume status perturbations, systemic atheroembolism, and hemodynamic changes. And these will occur to varying degrees depending on what kind of procedure you're doing. Our first look at coronary procedures, and that's where the bulk of our data involving acute kidney injury in the cath lab come from. are derived from the work from Roxana Miron, and this is the famous now Miron risk score, which has been around for 14 years or more. And the way Dr. Miron's group developed this score was that they looked at over 5,000 patients who underwent PCI. They had a developmental database which they used to look at comorbid conditions and procedural variables which predicted acute kidney injury. And at that time, they defined it as a 25% increase in serum creatinine, or 0.5 milligram per deciliter absolute rise at 48 hours after PCI. Once they developed the risk factors that predicted AKI, then they prospectively validated it in a separate cohort. And you can see the Miron score here on your left, and you can see that comorbid conditions are additive, but they're not equal for the risk of AKI. So that hypotension, hemodynamic instability, use of balloon pumps, for instance, have a much higher score than just having diabetes, for example. So it's an additive but not equal risk score. So here are the data from Dr. Miron's study, and on the left you see acute kidney injury and the risk of contrast-induced nephropathy, and on the y-axis you see the absolute incidence of contrast-induced nephropathy. On the x-axis you see risk scoring. So for low-risk patients, the risk of AKI was around 7 to 8%, and you can see that the very high-risk individuals, the risk exceeded 50%. Similarly, on dialysis, for the low-risk patients, on the right panel, dialysis risk was low with the low risk, and obviously rose very significantly in the very high-risk people, exceeding 12%. So these data were revolutionary, and they were further augmented by the fact that if you had acute kidney injury in the Miron study, your one-year mortality was increased. So if your risk of AKI was low, your one-year risk of mortality was low, but as that risk increased, you actually had an independent risk of dying. So really brought acute kidney injury in the forefront as a complication which has long-term outcomes. Now, as I mentioned, this score was published in 2004. It's been well validated, and it's still a useful tool, particularly when we counsel patients on the risk of dialysis. However, since then, over the last decade and a half, we've evolved in terms of our understanding of kidney injury, and we now know that even smaller increases in serum creatinine are important. And so first the nephrology community, then eventually the cardiology community has gravitated to the 0.3 milligram per deciliter absolute increase in serum creatinine. And this is the Aiken criteria, as you can see. So using more contemporary definitions of AKI, how do we look in terms of procedures? So these data are from the NCDR Cath PCI registry, and those of you who are not familiar with it, it's the large US-based repository of inpatient data with respect to percutaneous coronary interventions, or PCI. And the registry is co-sponsored by ACC and SCAI. The key study with relevance to AKI was published by Tom Tsai and colleagues, where, similar to the Miron experience, they took a database cohort. In this case, it was nearly 1 million participants who had their data entered into this prospective data set, and they examined the incidence of Aiken-defined AKI, so the more contemporary definition. They again looked at incidence of dialysis, and they looked at multivariate predictors of AKI, including baseline eGFR and the AKI risk. So here are the findings of Tsai and colleagues. We can see that if we look at any acute kidney injury or a need for dialysis, the risk was about 7.1%. And we can look then at the varying degrees of severity of AKI using the Aiken criteria, and the risk of dialysis, which was quite low at 0.3%. So these are the more contemporary data. In some sense, mirroring a lot of what Dr. Miron's group found, but providing a updated serum creatinine cutoff. Here are the data from the same publication looking at the baseline GFR, and so normal all the way to severe with GFRs less than 30, and looking at the risk of developing acute kidney injury and dialysis. And you can see that eGFR is a powerful predictor of acute kidney injury, with an eGFR less than 30 being a notable cutoff for a marked rise in both the incidence of dialysis as well as acute kidney injury. The other risk factors were also looked at, and you can see in this forest plot on the right, all the way from a contrast dose as little as 75 units or milliliters, all the way to severe GFR at baseline. You can see a graded increase in the odds ratio of developing acute kidney injury. So we have the expected risk factors of diabetes, chronic kidney disease, and age. We have now evidence that contrast dose as low as 75 mLs is a risk factor. And again, we see balloon pump use, shock, urgent revascularization, STEMI, these factors of the unstable patient, hemodynamically challenged patient. We see that that's a big risk factor for acute kidney injury. Again, mirroring what Miron found in 2004. When we look at individuals who are more or less likely to end up on dialysis, the strongest risk factor is having severe baseline renal function going into the PCI. So if you have severe GFR at baseline, your odds ratio or hazard ratio is 28.5, as you can see, for developing dialysis. So, you know, we can now take both our experience from Dr. Miron's group as well as Tom Tsai's publication, and we can put it together in what I would like to call a comorbidity spectrum for AKI. So all the way from contrast use to severe CKD, and these are additive risk factors that, when combined, progressively increase our risk of acute kidney injury. So what does this all mean for our patients? This is a common question I get here in San Antonio, where we have a high preponderance of diabetes and chronic kidney disease. Doctor, what is my risk of dialysis from this procedure? And so similar to being able to plug in the data for the Miron score calculator, a similar data calculator is available for the NCDR, AKI, and dialysis risk after PCI. The data for an individual patient can be plugged in, and we can get some sense of their risk of kidney injury and the risk of ending up on dialysis. So I feel like this provides me as a cardiologist with objective data to the patients, their families, to other providers about these risks, and it can help facilitate difficult decisions. Many times when we plug in these data, we find that the risk of acute kidney injury may be moderate, but the risk of dialysis is relatively low. And by sharing that information with the patient, I think we empower them to make more informed decisions about cardiovascular care. So for the second part of this talk, I really want to focus on understanding the key recommendations that we have and treatment options for these high-risk patients in the cath lab. And what I really want to emphasize before we even start this section is that prevention is really where we're at. We essentially don't have validated treatments for kidney injury once it occurs in the context of cath lab procedures. So it's really prevention and awareness that we're focused on. So in that vein, we have three basic strategies. One is to screen for risk. If we're not identifying high-risk people, we're not going to be able to prevent kidney injury. So for the high-risk patients, we want to consider a multidisciplinary approach involving nephrology, primary care, and cardiology. Use of more aggressive volume management. So that may mean augmenting the patient's volume with hydration before the procedure, during, and after, or it may mean diuresing the patient appropriately to reach euvolemia before contrast angiography is performed. We need to explore ways to reduce contrast, whether it's dilution, contrast modulation, use of isoosmolar contrast, for instance, staging of procedures, so avoiding large doses of contrast at a given visit, withholding potentially nephrotoxic agents, and that goes back to communication with the primary care and the nephrologist, avoiding nonsteroidals, potentially being cautious with initiation of ACE inhibitors. Use of high-intensity statins may have some benefit, and then actually closer follow-up of renal function after the procedure. When we talk about volume expansion, what we really are saying is that we need a protocol-driven method for giving volume to patients, a technique that takes into account their history of heart failure, their propensity to develop pulmonary edema needs to be considered, but we can't do angiographic procedures on patients who are volume depleted because that is a clear-cut risk factor for developing acute kidney injury. In addition, we might want to consider hemodynamics, as we'll see, to guide volume administration. And then when we can, to reduce contrast volume, so using the principle derived from radiation safety in the cath lab as low as reasonably achievable, so minimizing total dose. And again, considering isoosmolar agents when appropriate, particularly in patients undergoing peripheral angiography where they may have significant discomfort from a low or high osmolar agents. So the patients presenting to the cath lab can come in a variety of different volume states. They may be euvolemic, in which case we might expect that they have rapid contrast excretion and decreased risk for acute kidney injury or contrast nephropathy. But many patients who are coming in are NPO. They may be volume depleted. Potentially they've been aggressively diuresed in the context of heart failure, and this predisposes them to increased dwell time for contrast within the kidney and low urine output, and together that increases the risk of contrast-induced nephropathy. Of course, we all see patients who are hypervolemic, those who are decompensated in heart failure or acutely unstable in cardiogenic shock. And those individuals also have increased dwell time due to a combination of low renal perfusion feeding the kidney and a high renal vein pressure, so that the problem is not simply perfusion, but emptying of the renal structure by the renal vein. So this also increases contrast-induced nephropathy risk. So figuring that out, where your patient is along that spectrum, is very important. Understanding whether they're euvolemic, hypervolemic, or volume deprived, and appropriately managing fluids. Most patients that you'll encounter may be actually volume depleted when they come to the cath lab. And so for those individuals, we have to have a protocol-driven hydration strategy, and these are just some examples of different healthcare systems and protocols that are used. Normal saline, sodium bicarbonate. The data would suggest it really doesn't matter which one you use, that certainly sodium bicarb is not clearly superior to normal saline. But the key point here is to give adequate protocol-driven volume expansion. These are data from the Poseidon trial, which was published by Sam Brar and colleagues from Kaiser Permanente. And the principle here was to actually measure the filling pressure in the left ventricle, something we do on the vast majority of cardiac catheterizations. And if the filling pressures are high, you're going to give less contrast, and if they're low, you're going to go ahead and give more volume rather for volume expansion. So, and does this strategy actually work? So by giving more hydration volume to people who could tolerate it versus those who got standard hydration, you can see that major adverse events, specifically acute kidney injury, was substantially lower in those who got LV-EDP guided hydration rather than those who simply got a standard control hydration strategy. So we're doing this measurement anyway on patients. We're measuring the EDP. We can put it to use by tailoring how much volume we give patients for prevention of AKI. Another strategy is to couple volume administration with forced diuresis. This is not necessarily a novel concept, but has become technologically somewhat easier with the introduction of the renal guard system, and this is a system that measures urine output and then augments hydration, and this is coupled with forced diuresis with a high dose of furosemide. So by providing input and augmenting output, we can increase flow of contrast through the kidneys and enhance excretion of contrast out of the body. This is a meta-analysis that my group published recently, looking at a variety of different clinical scenarios, including PCI and TAVR, and looking at the impact of renal guard versus standard hydrational therapies. And you can see that there was a substantial signal towards favoring renal guard in terms of acute kidney injury compared to routine volume expansion. So we're talked about contrast and in this last slide and getting rid of contrast. So why does contrast volume matter? And these are data from Hithendra Gurm's group where they looked at the incidence of contrast nephropathy and the risk of dialysis by using a ratio of total contrast volume over the patient's creatinine clearance ratio. And you can see that for the most part, the risk stays quite flat, but as we start increasing the contrast volume to creatinine clearance ratio, certainly increasing over 2 and then steadily over 2.5 and then more markedly over 3.5, the rate of both dialysis and the risk of acute kidney injury increases substantially. So contrast volume as a ratio of baseline renal function is an important metric. Similarly, here are the summary data for contrast nephropathy, again from Gurm's study, and you can see the rate substantially rises when that ratio is above 3, and 3 is an easy number to remember. So in the Cath lab, contrast volume over creatinine clearance ratio, if it's 3 or more, that patient is at substantially higher risk of developing contrast-induced nephropathy. Contrast recommendations have made their way into our guidelines. So these are the 2011 ACC/HA guidelines, and you can see that they recommend assessing a patient's risk for AKI before PCI, that the patient should be hydrated, and that the volume of contrast really should be minimized in these individuals, and they use a creatinine clearance of less than 60 as their threshold to really bring attention to contrast media volume. SCI guidelines also recommend monitoring contrast dose in real time, and they give a contrast dose limit of 3.7 times the eGFR. It really doesn't matter whether you use 3 or 3.7. The point here is that there have been a variety of different contrast thresholds that have been looked at over time. The older ones used grams of iodine to eGFR or 5 times body weight over serum creatinine. I think with the data that we have, both from the NCDR data set as well as Dr. Gurm's work, we can safely say that 2 to 3 times the eGFR is probably a reasonable number to remember and to use as your contrast threshold. So how are we actually doing with AKI prevention? We asked this question this past year. We said, let's look at guidelines, consensus documents, and best practice statements, summarize what we are doing, and then let's see what cardiologists around the world are actually doing. So we came up with 20 questions that we sent out to over 2,000 cardiologists, spanning the spectrum of prophylaxis all the way to post-procedure management, contrast management, medication management, and risk assessment. We asked these in the form of a Likert scale. And then we also had specific questions within those 20 that were what we felt evidence-based. So they had actually a right answer. And we felt that we could say that there was a right or wrong answer based on guidelines and consensus statements. So when we looked at the questions specific to cath lab management of contrast, for instance, how did people do? And so this is the distribution of scores, where the higher score is better, the lower score is worse. And we can see that the vast majority of people did well. So if you're a glass half full person, this is great. But 40% of the respondents did below average. And so 40% of cardiologists reported not using contrast threshold limits or accurately measuring contrast use during the case. So 40% is still a big number of cardiologists, and I think this points to the need for further education, further emphasis on AKI prevention. More recently, when we want to see how a broad group of physicians, and these are data again from NCDR from Amit Amin's group, how are people doing with their use of contrast? And here you can see the distribution of contrast volume use, and on the x-axis is simply physicians in ascending order of volume used, and you can see there's a large variation. You have some that are using less than 100, and then on the extreme, you have people who are using 400 plus mLs of contrast. So we would think that we're using more contrast on our complex patients and less contrast on our low-risk patients. But what we find is that AKI risk really doesn't correlate well with mean contrast volume. So for the high AKI risk patients, the ones who are more at risk of dialysis, for instance, we're using just about the same amount of contrast as we are for the lower risk patients. So clearly we have an opportunity here to decrease the contrast volume that we use during our cases. So what are our approaches to doing this? We can use very low contrast dye for PCI. We can use adjunctive imaging, FFR, IVUS, potentially non-contrast OCT. We can obtain limited angiographic images, which is a double-edged sword. We can miss lesions if we're not careful. It's helpful to emphasize that many folks use biplane angiography, but certainly if you look at the literature, biplane angiography has never been shown to decrease the risk of acute kidney injury, nor does it reduce the risk of radiation for that matter. We can consider use of isoosmolar contrast, again, maybe have particular benefits during peripheral angiography. And the techniques of ultra-low contrast PCI are still emerging and frankly may not be suitable for all patients. We could consider use of automatic injectors, which provide controlled delivery of contrast, but unfortunately the data from automated injectors has shown that although we do lower contrast volume, we do not decrease the risk of AKI. In our survey, about 20 to 30% of cath labs in the United States use automatic injectors. More recently, we have evidence that we can change the way we give contrast and monitor contrast with some new technology. We can use real-time contrast monitoring, similar to what we do for radiation, where we have a digital readout of the amount of contrast that we're using. And we can automate hand injections. And again, hand injections through a manifold system are the most common way cardiologists are administering contrast. So by intervening within that setup, we can introduce technologies which may help decrease dye delivery. So focusing on the as low as reasonably acceptable principle, this is, for instance, contrast modulation and monitoring technology. This is the Divert Plus system, which is a self-adjusting system which helps reduce contrast delivery. But what is quite unique about the system and a real refreshing change from the way we monitor contrast use is there's a digital readout from a smart syringe that tells us how much contrast we're actually giving to the patient, both with each injection and the cumulative volume. So it's less guesswork. less trying to estimate from the bottle how much we're using, and more real-time data that can help physicians make decisions about when to continue, when to stage procedures, etc. So, for instance, this setup is for the Divert Plus. The contrast saving component of it actually connects to the manifold and is able to reduce forward delivery of contrast to the patient by, on average, about 40%, and that's done through a pressure compensating valve. The contrast that's diverted is then used for the subsequent injections. And this is what the readout looks like that we just mentioned, where you have a cumulative volume, injection volume, and you can get a % savings, or it can also tell you the contrast that's actually in the syringe. And obviously, you can also then compare in real time with the system the amount of contrast you're using against the threshold that you have set based on your eGFR. Big question is, how accurate is this? Do you really need it? Can you just guess? Well, what we found in our validation study was that the contrast monitoring system was better than physician measurement for contrast use, and comparable to a very meticulous direct measurement where we suctioned out every drop of contrast out of the system, and we found that the smart syringe is actually quite smart. So if you're decreasing contrast delivery, will you have a bad picture? And the reality is it's difficult to tell that the system is off or on. You still have excellent image quality for clinical decision making. And so what does this mean? If you're using 40% less contrast but you're still getting good pictures, what's the lesson here? And the lesson is we likely use more contrast dye per injection than is necessary for high-quality coronary angiography. So the validation study has been done, and this was a prospective randomized controlled study performed in Germany looking at the use of the contrast modulation system in a variety of different scenarios. The vast majority were coronary, and on average there was a 40 to 49% contrast savings. You can see here an average of 49% less contrast volume that was delivered to the patient. The volume delivery was similar, and the savings were similar to femoral versus radial, as well as a small number of peripheral cases. And the image quality was adequate. Over 99% of images were assessed as acceptable for clinical decision making, and a very rare number of times did the image quality become inadequate, requiring the physician to turn off the system. So let's put it all together, and we're going to finish with a quick case. This is a 72-year-old diabetic female presented at the hospital, worsening angina, decompensated heart failure, reduced EF. She has known coronary disease with severe ectatic calcified vessels, who's been turned down for bypass grafting, and chose really to be medically managed for several years until her anginal frequency increased. The elephant in the room is the fact that she has stage 3 chronic kidney disease. eGFR is 51, and you can see her serum creatinine is 1.3. Here is the angiographic images demonstrating serial lesions in her left anterior descending coronary artery, ectatic vessels. Baseline flow is quite slow, TIMI2 flow, and consistent with diffuse endothelial dysfunction. So in addition to all the factors related to intervening on an ectatic calcified vessel, on top of that, we have concerns of acute kidney injury. This is a patient who has congestive heart failure. If we use volume expansion, when do we hold her diuretics? How much volume do we give her? Do we hold her ACE inhibitor ARBs? Do we need ventricular support in someone with low EF who may need atherectomy of a calcified vessel? And should we get the nephrologist's input early in the process? So a lot of factors that go into decision making. Our procedure involved ventricular support, assisted PCI, rotational atherectomy, which results in hypotension. Obviously, we discussed earlier that hypotension is a risk factor for AKI. The patient required inotropic and pressor support. Eventually, the patient undergoes successful stent placement with a large stent, and you can see that the patient had an acceptable coronary result. Did we avoid AKI? And the answer is yes. We had a progressive decline in renal function and no AKIN-defined increase in serum creatinine post-procedure. So how did we avoid AKI? Well, I think we screened for risk. We identified this patient as high risk for acute kidney injury. We staged the intervention apart from the initial diagnostic images. We used ventricular support in anticipation of hypotension. We actually found that the patient was volume depleted on initial hemodynamic measurements, so we hydrated the patient. We reduced contrast volume. We used contrast modulation, and were able to save additional contrast dye, despite using the 8 French sheath in this case, which obviously results in more contrast delivery. So in conclusion, the points I really want to emphasize is screening for risk in your patients, making sure they're adequately hydrated, and reducing the contrast volume that you use. These are all important things that we can use on every single case. And by doing that, I really think we can reduce the risk of acute kidney injury in our patients. Thank you.